researching access to rural sexual assault care in Northern Ontario. Before we get started today, I just want to acknowledge that McGill resides on the land that has long served as a meeting point and exchange point amongst Indigenous peoples, including the Haudenosaunee and Anishinaabe nations. McGill honors, recognizes, and respects these nations as traditional stewards of the lands and waters on which we meet today. So today we're lucky to be joined by Dr. Marian MacCallum. She is visiting the St. Mary's Research Centre this June as part of the McGill University Glasgow Exchange Program, and she's collaborating with Dr. Jeannie Haggerty, the McGill Chair in Family and Community Medicine Research at St. Mary's. She is a practicing family physician in Scotland who's doing her PhD in the Department of General Practice and Primary Care at the Institute of Health and Wellbeing at the University of Glasgow. She has been a member of the GPs at the Deep End group for the last 5 years, and she's going to explain a little bit about this in her presentation today. Her doctoral dissertation is a mixed methods exploration of individual and community factors that influence management of multimorbidity in the context of high socioeconomic deprivation. Methods include meta-ethnography, a quantitative analysis of the influence of individuals and community factors on mortality, and an ethnography as a primary care physician in a community experiencing high levels of socioeconomic deprivation. So just want to remind everyone today that the presentation will be about 30 minutes, then we'll have 25-minute follow-up of discussion. The seminar is recorded, so if you don't want to be in the recording, just turn off your video. And if you have questions during the talk, just put them in the chat and we'll read them out at the end, or you can raise your hand at the end during the question and answer period. So without further ado, I'm just going to pass the mic to Jeannie. She has a few words before we get started with the presentation today.
Thank you, Sydney. I really appreciate that. I wanted to also extend a welcome to Marianne from Scotland. And I wanted to just take a minute to tell you a little bit about that there is this exchange between McGill and the University of Glasgow, and especially dedicated for young investigators. I wanted to tell you a little bit about that. I'm going to just share you what it looks like. I did not know, but it turns out that James McGill went to the University of Glasgow, and ever since then, we now have this relationship with the University of Glasgow, and there is a travel award for early career researchers. It's an amount that covers up to $5,000, and it's destined to McGill PhD and postdoctoral students in all programs. It seems to be very open eligibility, and there's a yearly intake. So in January, this was last year's, but keep an eye out as to when this will be, and especially it would encourage postdoctoral fellows and researchers to think about this, especially if you find today's talk really fascinating and you just want to find out a little bit more about the group that Marianne is working with, because I think there's a lot of coherence with what we're trying to do. And just before I go, I just have this little silly thing. I wanted to do just a teeny little Scottish-Canadian dictionary. As we've been chatting back and forth, I've been keeping some notes about what means what. So the first thing is that a GP is a general practitioner, and that's a family physician. That's our family physicians. And when people have bike injuries, they go to the A&E instead of the ER. Who knew? But that's good. Marianne's very disciplined and has been trying to say ER, but A&E slips in. A consultant is a specialist. A registrar is a resident, like they're in training. When she talks about health boards, they're quite similar to our regional health authorities. It's a kind of devolved governance council, or maybe now our CSIS and SUSIS, I'm not sure. Just a little thing, M means so we hear that a lot, and at first I was thinking it was the letter M, but it really means A council is anything that's in the public domain, like council swimming pools, and council housings will be social housing projects. And then there's this thing called the third sector, which is the non-governmental organizations, which includes charitable organizations. So really, this is my winnings so far. And if you hear anything that you're saying, okay, what is that? Put it in the chat, and we'll see who can get to you with the Canadian equivalent as fast as possible. But we're going to have this wonderful dictionary by the time we finish. So over to you, Marianne, and really looking forward to it.
Thank you, Jeannie, and thank you, Sydney, for those introductions. It's very appreciated. So I'll just set my slides up. So yeah, as has been said, I'm Marianne. I am a family physician working in the west of Scotland, and I'm also work at the University in Glasgow as a researcher, a clinical researcher, and I'm currently doing my PhD. And my research interest is really around communities experiencing high levels of socioeconomic deprivation or poverty, and how that experience influences their experience of health and the decisions they make, and how we can hopefully look to create systems that improve outcomes for these more vulnerable populations. So before I begin, I'd just quickly like to make some acknowledgements. First of all, the Chief Scientist's Office in Scotland for funding my PhD, my colleagues at the GPs at the Deep End Steering Group in Scotland, particularly Drs. David Blaine and Carrie Loonan, who helped create some of my slides. I'd like to acknowledge the University of Glasgow Early Career Mobility Scheme, which is our sort of Glasgow McGill side, who have given me the funding that's allowed me to be able to come out here and spend time in McGill. My PhD supervisors, Professors Mayer, MacDonald and Lucy, and the wider team at General Practice and Primary Care at Glasgow University, some of whom's work I'm sharing today, but also who together create a really inclusive and wonderful place to work. So just to be clear, I have no conflicts of interest to declare. So very briefly, the outline of what I'm hoping to talk about today is very quickly give you some context about the UK health system and the ways in which it differs from here in Canada. I'm going to sort of talk about some of the health inequalities in the UK and the impact of them on both patients and practitioners. I'm going to very briefly touch some of the traditional ways in which we've approached these inequalities in the past, and then talk about some of my PhD work and the reasons why I've chosen to approach this in this way. And finally, I'm going to just briefly touch on this group called the GPs, or General Practitioners at the Deep End, which is a practitioner-led group which has been set up in response to some of the inequalities that our patients experience. So very briefly, in the UK where I'm from, healthcare is provided by something called the National Health Service, which we British tend to be a bit fanatical about. It's taxpayer funded, and it basically means that there's universal health care for everybody, free at the point of need. So that covers all types of healthcare, including things like physio, occupational therapy, and all mental health services. Another thing that's slightly different is our medical training. So in the UK, we would undertake a 5-year undergraduate medical degree, at the end of which we would have 2 years of hospital foundation training, at which point we would then choose our speciality. So in the UK, what you call family medicine, we call general practice, and it's a recognised speciality and would require about a further 3 to 5 years in training, depending on the programme you go for, and that would be a mixture of hospital and community placements. And general practice is seen as very important in the UK. So it's would be said to be the foundation of the NHS. So over 90% of all clinical NHS encounters occur in primary care, and we do that for less than 8% of the budget. And we traditionally act as gatekeepers. So to be able to access any secondary care, specialist services, you would require a referral from your GP. So what I'm talking about are inequalities in health and in health outcomes. But when we talk about inequalities in health, I think we need to recognise that we have inequalities in health because we have inequalities in our society more broadly. So this is a picture from the Scottish Index of Multiple Deprivation Map, or SIMD. So this is a national measure which basically breaks the whole country into postcodes and measures deprivation using several things, including housing, employment, access, health, education. It then ranks every single postcode and then splits them into deciles. So we have deciles depending on the level of deprivation in each postcode. So what this map shows is the colour related to the amount of deprivation in the different areas across Greater Glasgow. And the redder an area, the more deprived we would say it is, and the bluer an area, the more affluent it is. And as you can see, there's a real mixture across the city, but generally what you get are these clumps of very deprived, very red areas, often next to clumps of very blue, very affluent areas. And what this means in reality is that we have differences in health outcomes. So one of the first ones that's very obvious is we have a quite significant mortality gap. So what this picture is of some train stations in Glasgow. So if we start in Jordan Hill, in an affluent area in the west end of Glasgow, the life expectancy there for men is 78. And if we carry on down the train line through the centre of town over to the more deprived east end, to Bridgeton, the life expectancy drops to 63.7. So that's a 15-year gap in life expectancy for men and about 11-year gap for women. And it's important to note that that train journey takes you about 20 minutes, and these two areas are only about 6 miles apart from each other. However, it's not just that you die early if you live in the most deprived areas in Scotland. It also affects the illness you experience. So this graph is from a landmark study looking at multimorbidity in Scotland. And as you would expect, the proportion of people who have 3 or more long-term conditions increases by age. But the rate at which that increases varies by deprivation status. And as you can see, in our most deprived communities, multimorbidity starts about 10 to 15 years earlier. So not only do people have a 10 to 15 year reduction in life expectancy, they also have a 10 to 15 year reduction in healthy life experience. Oh, sorry, I'm not sure what I've done there, just a minute. And this is particularly marked in the area of mental health. So this is from the same study. And what it shows is as the number of physical disorders increase, the proportion of people who have a mental comorbidity also increases. But this happens at a much higher rate in deprived communities. And that has a significant impact on the patients themselves and their experience, but also practitioners who are managing these populations. And this is seen at a national level. So what this graph shows is the red and blue is the mortality and morbidity load across the different deprivation deciles. And as you can see, it goes up significantly the more deprived the communities are. But actually, the black and green lines show the numbers of GPs and the funding across the deprivation deciles, and it's a flat curve. And so what we end up is the significant gap where we have a huge amount of clinical need, but no increased resource. And that puts a significant strain on practitioners. And we know that practitioners working in these populations tend to see more patients with more problems in less time, and therefore are understandably more likely to be stressed when that's measured. However, it's not just this increased clinical load that causes a strain for practitioners. This is a quote from a study that I carried out exploring GP work in deprived communities. And this GP described it as multimorbidity plus. So it's not just the multimorbidity itself, it's plus the fact there's literacy difficulties, or maybe the need for translators, or maybe there's issues with benefits. It's trying to manage this increased multimorbidity with the increased social complexity at the same time without any extra resourcing from the system. And when you look at how working in these areas influences GP work, well, it influences it at every single type of work. But in particular, what practitioners experience is this, what this GP describes here is this huge raft of hidden work, this extra work that these practitioners are doing to support their patients, acting in an advocacy role, dealing with medicines compliance, ability to access hospital systems, ability to access appointments, making sure people actually turn up, following up when they don't. And that is a huge amount of extra work that is not recognised by the system and is also made worse by the system itself. So these GPs talk about seeing all these extra hidden barriers that their patients are experiencing, and all of this increases their experience of stress. Finally, there's also this extra work that certainly in the UK, we don't really acknowledge very well, this idea of emotional work. So this is the work that we do as practitioners to manage our own emotions when we're managing people who are going through distressing situations. This GP described it as a greater potential in your day to be emotionally knocked. And the experience that she says of saying, I think it's difficult sometimes to realise what awful lives some people lead, and you have to share that with them. And it's the fact that you're doing that with person after person in a situation that's highly pressured without a huge amount of space and ability to be able to manage or find space to manage those emotions. So that's a sort of quick run through where we are with inequalities data in the UK. I just briefly wanted to talk as well on something that one of my colleagues, Dr. Williamson, is doing, looking at this idea of missingness. So these are patients who routinely miss GP appointments. And what we know about these patients is they have an increased risk of all-cause mortality. And that's particularly in those with mental health diagnosis. They're far more likely to use outpatient or specialist secondary care appointments, and they've got a higher rate of hospital admissions, so they're costing the NHS a lot more money. And this group also has a very significant association with low school attendance, exclusion, and lower educational achievement. So what I've been describing is the experience of managing the people who actually turn up. But we do also need to remember that there's probably another raft or part of our population that's particularly vulnerable, that's not even managing to access our primary care services. And that's even in a universal system. So what that means is that we have these awful inequalities in income, and actually I think all of us would want to do something about that. But actually for about the last 20 years, the UK government's been investing in health inequality research and work without really making any difference in our outcomes. And in some cases, our outcomes are becoming worse. And I think that's in part because really the reality is what we have on the right, which is that we have populations where we have people with really different amounts of resources, and we don't really take that into account in our system. And an awful lot of what we do is maybe aiming for this equality thing on the left, but actually I think we need to be aiming for equity. We need to recognise that there are proportions of our population that are potentially going to require more resource and more support just to get on the same level playing field as other people. And in the UK in general, a lot of the health research, inequalities research, has looked very much at behaviour choices, at trying to improve people's behavioural choices. And this is very much seen as the reason for the inequalities, certainly from the politicians and the media's point of view. However, there is becoming a bit of a backlash from this. So this is a poster by our cancer research charity in the UK, and it came from a good place. I think they were trying to talk about how trying to get people to realise that obesity is a risk factor for cancer. But this poster caused a huge amount of uproar, and as you can see, somebody has graffitied it to say actually poverty, inequality and austerity, so that's the cuts that the UK brought in after the housing crisis, are significant drivers of things like obesity and therefore cancer. And so this recognition that actually these inequalities in our health are actually being driven by wider structural factors. And when you speak to people who are from these communities, that is something they recognise. So a meta-ethnography looking at the experience of these communities and how they understand health inequalities showed that, first of all, they recognise health inequalities but see them as a result of social inequality. And there's a big amount of stigma associated with these outcomes or people talking about them because of this awareness that society in general views these inequalities as down to people making poor decisions. However, when you speak to these communities, they frame these health damaging behaviours as rational, even inevitable responses to the difficult circumstances they find themselves in. So what you have is a tension between what the health community is saying, which is people need to improve their choices, and what these communities are experiencing, which is a lot of this doesn't feel very much like a choice. And actually, even when we look at these healthy, unhealthy choices, we find that there's something bigger going on. So this is work by my colleague, Dr. Foster, and the green bars are sort of a healthy lifestyle. So he created a score. So those are this is the healthiest lifestyle score, up to the red, which is the unhealthiest score. And as you'd expect, across the deprivation quintiles, an unhealthy lifestyle score increases your hazard ratio, increases your risk of mortality. However, that effect is significantly more marked in our most deprived quintile, suggesting that there is something about structural health inequality itself that is driving these outcomes. And this is backed up by other work. For example, behavioural risk factors only explain 40% of this difference in multimorbidity prevalence across socioeconomic deprivation. So with this in mind, I was quite keen with my doctoral work to sort of try and have a look at some of these community factors and try and understand them better. And I'm going to present very much the qualitative aspect of my PhD. And I use something called burden of treatment theory as a lens of what I'm trying to explore. So what this is we have treatment burden. This is the work that we as clinicians give our patients to do. And we also have capacity, which is people's ability to carry out that work. And that can be influenced by all kinds of things, whether you have access to transport, your literacy levels, whether you grew up somewhere that was nurturing and safe. But what we do know is that when the work that we give people outweighs their ability to carry it out, poorer outcomes persist. And there's been quite a bit of work looking at treatment burden and trying to reduce the work we give people. But actually what I'm interested in and what I think is potentially quite important in the sphere of health inequalities is capacity. What people can actually do, which is something we as clinicians really don't tend to ask very often, and how we can enhance that. And the thing about capacity is the community that you live in can enhance or reduce your capacity. So whether you live somewhere where there's lots of shops and lots of fresh fruit and easy access to vegetables, or whether you live somewhere like where I work, where the nearest supermarket is 2 miles away, and there's no bus that goes there. So that's an issue for people with mobility and small children. But there is an ice cream van that goes around the scheme and sells cheap processed food and probably other dodgy stuff. And so in that context, it's really actually a lot of extra work and hassle to make healthy choices. So what I was looking to explore were these sort of individual and community factors. And so what I'm doing is looking at a community in Glasgow called Drumchapel. And this is it on that map that I showed you earlier. And as you can see, it's entirely red, but interestingly, it's surrounded by a sea of blue. And that's actually quite important in terms of how the people in the community see themselves as quite cut off and looked down on by these areas of affluence around them, and chose to take an ethnographic approach to try and understand some of the hidden things that are going on, to try and understand some of what we would maybe call the unwritten rules, and the way that information is transferred across this community, to try and understand some of the things that sort of underlie the decisions people take. So I'm interested in trying to pick out people's private story, which is what they actually do, versus their public story, which is what they tell you they do. So I was all set to spend 2 years in as many different community groups as it would have me in Drumchapel when COVID started. So that meant I had to take a slightly different approach. I had to move around some of the work that I was doing in my PhD. And over the last few months, I've been slowly trying to spend time in Drumchapel, but obviously I had less time than I initially planned. So I've actually just been focusing on spending time in 4 community groups. So that's been a parent support group, a community garden, a men's mental health group, and a cycling group. I've also been recruiting through the local GPs to carry out in-depth interviews with people who have multimorbidity, and then I'm going to be following up when I get back with some focus groups to sort of present back my findings to see whether people feel they ring true. I'm also hoping to carry out some asset-based workshops as a participatory research method. So asset-based workshops come from the discipline of community development, and it's basically about how it's sort of working with people from the community to identify key assets. And I'm hoping to do this as a way of sort of looking at exploring community capacity. And I'm hopefully going to be able to doing this now with 2 of the groups that I've been working with. So I'm just very briefly going to share some of my interim findings. One of the first things that's coming up is the shared community experience, 2 key things. First of all, what it's like when none of the systems work for you. So that's not just health, it's housing, it's social services. None of the systems work for you, and they don't just not work for you, they don't work for anybody you know. And this quote here is from one of the patients I interviewed, and he's talking about Bears Den, which is a very blue, that kind of very blue affluent area just next to Drumchapel on the map I showed you. And just this experience of, well, if 2 people are going and one's from Bears Den and one's from Drumchapel, the person from Drumchapel is just not going to get the job. It doesn't really matter because that's the way the world works. And there was lots of stories and experience of people of this being their experience. In addition, there was this shared community experience of shame and stigma. So the community itself actually has very high levels of social capital. People know one another and help one another out. However, they also know that they are known as being from Drumchapel. And as soon as people find out where they're from, they look down on them. And that can potentially be understandable. So this is a quote from a woman talking about the centre of Drumchapel, which is really pretty run down and not nice. And she describes it as a dump, and how that makes her think, is this all I'm worth? She says, if you live in a place that looks good, it makes you feel better, but that's not her experience. But what she says, if you go down and you see kids throwing it away, it's 8:30 in the morning, they're eating sausage rolls, that's their breakfast. This sort of recognition of some of the problems in Drumchapel that are just so visibly obvious, and being aware that wider society tends to look down and condemn them and their community because of that, and that they're therefore condemned. And what this shared community experience means is that it fundamentally alters the way that people approach all official services, and that includes healthcare. And that's really important because most of us as clinicians and policymakers tend to assume people approach health services in a particular way, but this kind of suggests that actually there's not a huge amount of trust for people from these communities. Finally, the importance of holistic care or person-centred care seems to be particularly an issue in this community. So this quote is from a woman who had come from another area and moved in, and she'd felt like her previous practice saw her as a person. So she says here, whereas her current practice doesn't. So she said, the people here, the GP here, they don't give me confidence. But back there in her other GP, she felt it was personal, that they gave you that personal touch, that they were interested in your life. Whereas she's describing here that she feels that her current GPs, she's just a job to them. They're just interested in her diabetes and her HbA1c and not really anything else. And this came up again and again, that continuity and care, continuity and relationship were really, really important for people. And where these existed and where people really trusted their primary care practitioners, then they saw their primary care or general practice is different from other official services. They saw their GPs as being for them. That was really important. But where this didn't happen in primary or secondary care, it reinforced this feeling that none of the systems worked for them and that people didn't care. And people tended to respond in 2 ways. They either shut down and didn't engage, or they got angry. And neither of those were particularly helpful responses for them. Yeah, the other thing that is key is that post-COVID, we're doing an awful lot of telephone consulting. There's a lot more difficulty accessing GPs, and that was causing a significant issue and strain in the practitioner-patient relationship. Finally, from some of the community groups, several of the groups were particularly good at managing to engage and help support change for people who were very vulnerable. And there were some key things that seemed to be important for this to happen. The first was that the group needed to be seen as authentic and rooted and part of the community. And that was very, very important for people because there was a lot of experience of other people out with their community coming in. And so there was something really important about that community recognising Drumchapel and what was important to it and building up around there. Also, the workers in the groups were very, very good at creating what I call safe spaces. So this was a place that people could come and know they wouldn't be judged. And that was very, very important and a key part of people engaging. The successful groups also were very, very good at utilising peer educators and peer supporters, and this was incredibly important for people. There's something very powerful about seeing people that you knew and seeing that they had changed, and that gave you confidence to think that you might be able to make changes. Finally, these groups seem to very, very carefully and very skillfully manage this tension between creating this safe space, which is important, but also ensuring people progressed and changed and moved on. And so they were very, very good, particularly the experienced kind of charity and community workers, at working out when people just needed that safety and support and when they actually needed challenged to help move on. And I think what's really important is that this is the exact opposite of almost all health interventions, which tend to almost always be practitioner-led, time-limited, fixed and predetermined, and often in healthcare settings. And this may be one of the reasons why a lot of interventions tend not to be picked up by vulnerable populations. So I'm just quickly going to talk on the practitioner experience again. So I'm just going back to that graph I showed you with this gap. And what we as practitioners would say is what this gap represents is the gap of what practitioners can do compared to what they could do if resourced. And there is a real desire to try and increase that resource and to try and look at what primary care could do to reduce these inequalities in health. And it led to the starting of this group called General Practitioners at the Deep End. And the folk who founded it essentially turned that graph upside down and thought, oh, it looks like a swimming pool. And what they described as the GPs who are working in these areas of huge unmet need, it's like they're at the deep end of the system. And that's where the phrase came from. And so what they did at the start was they essentially chose the 100 most deprived practice populations in Scotland. And what they did was use routine collected data. And so this shows you the proportion of people in the most deprived quintile in each of the practices across Scotland. And they cut that off at 100, which was an arbitrary point. As you can see, there's not a huge difference between practice 90 and practice 110, but there needed to be a cutoff, so that's where it was. And what they did was they brought these practitioners together to share experience. And what happened was that this, I think, was one of the first times this had ever been done. And what happened was you found people who'd been working often on their own or in small practice teams in these areas, realizing that some of that stuff I was talking about, the hidden extra work, the way the system didn't work for their patients, it wasn't just them that was seeing that, it was this collective group. And what they did was they basically created these different reports from roundtable discussions with experienced practitioners. And there's lots and lots of them available on our website. And a sort of what this slide just shows is a summary of some of the key things that's come out from them. So in the one box, you've got key issues that affect our deep end communities, and then key points about deep end clinical encounters. So some of the stuff I've already talked about: early multimorbidity, social complexity, shortage of time. And since the group started, it's grown and grown. It's really found a voice, and lots of practitioners working in different areas of deprivation across the UK, over in Ireland and Australia, have recognised something in their own experience and started to set up their own groups. So this is the list of the groups that we had in 2021, but there's more sort of coming along, and they're all doing different things. They're all practitioner-led, but working in their different contexts, either across the UK and in Ireland. And in Scotland, what that's looked at is we've had several projects. We've the Links Worker projects, which was a social prescribing project, where we sought to put social prescribers who were beyond, they weren't just signposting, they were actually trying to take some of those things that work well in the medical generalist setting and apply it in a social setting. We also had a governorship project, which was multidisciplinary team working across 4 practices, sort of targeted vulnerable groups of patients and had large and we essentially brought together all the different groups of people working with them, from community nurses to health visitors to social care workers, to try and come up with integrated solutions, and that worked really well. And then we've done a variety of things, attaching different types of workers within our practice teams, often showing a much better improved outcome and effectiveness when these people are actually integrated in the practice team, which often has this sort of trust and relationship that I was talking about earlier, rather than just being an outside organisation coming in. We've also been doing a lot more advocacy work, trying to advocate for our populations, particularly through COVID, explaining what it is that we're seeing as groups of practitioners across our communities, and how they're being particularly affected by different decisions. And we've also, we've been going for a while, but finally managed to get some work with the Scottish Government. So we were recently part of a primary care health inequality short life working group, and are hopefully in discussions with the government about trying to look at ways in which we can fund and resource this gap that I was showing you about in the graph. So in conclusion, we have the ongoing structural societal inequality we have continues to result in these persistent health inequalities, and this has a significant impact for practitioners and patients. The influence of social stigma on access and treatment decisions needs to be considered in health system delivery, and I think we ignore that at our peril. The GPs at the deep end experience is an example of practitioner-led solution, and it's a model that may be of value in other settings. Future interventions need to go beyond this focus on individual behaviour choices, and instead also need to focus on community as well as individual level factors. And I think we also need to be really looking at how we can enhance individual capacity and empower people, because at the moment a lot of what we do is quite disempowering. Finally, future multimorbidity interventions and health service designs that are targeting these communities should seek to involve patients, find ways to make sure they're authentic and relevant for the communities they're in, empower, train and utilise peers wherever possible, and understand the importance of creating and maintaining a safe space as a prerequisite to engagement. Thank you for listening. I'm happy to answer any questions.
Thank you so much, Marianne. That was an amazing presentation. If anyone wants to raise their hand or unmute themselves and ask a question, you're more than welcome to at this time, or you can put them in the chat if you're more comfortable and I can read them out. Jeannie?
Thank you, Marianne. That was amazing. I've heard this talk as you were sort of talking about it to others, and every time I'm super impressed. Marianne, the question that I have is, how do you see yourself integrating into your clinical practice some of the best practices that you've learned from your community groups, like creating a safe space? What does the presence of authenticity mean in clinical practice? And how do you sort of balance that delicate balance between creating a safe space but also challenging when necessary?
So from what I understand, you're asking particularly how this is in my own clinical practice, and so as a family physician. So what I would say is that I actually think this is something by and large that we, when we're able to work in the way that we've been trained to and we have the space to, is what we as family physicians are actually very good at doing. Because actually, particularly so, I've always worked clinically in these kind of populations since I graduated, and I think what you recognize is that importance of the relationship, the importance of listening in those one-to-one consultations, and the importance of actually trying to understand what's going on. And I think for a lot of doctors who tend not to come from those kind of communities, like what I would say to medical students and trainee GPs is actually you've got to actually stop and listen, and you've got to try and understand, because that person's experience is going to be very different. You actually need to so I think what I hope I have been doing as a GP, and it is sort of allowing that space to listen, and then it is that thing as well of, actually part of my job, I could just be really lovely and just smile and just be this constant listening person. But actually, sometimes part of my job is to have those challenges. So I guess an example would be in the field of addiction and in people seeking sleeping tablets or wanting a medication to fix something. It's like being willing to have those difficult conversations. But what I've found is I generally, when you have those conversations, when you don't have a relationship, that's when things don't go well. And in a lot of these communities, trust is a huge issue. So I know that I'm a safe person, but what I always remind myself is that person speaking to me doesn't know that. So actually, I think when I first meet someone I recognize as a professional, I may need to prove myself before. And so I think that's something I've already been doing. And so maybe it's not so much applying that, but seeing these community workers doing something different, doing something the same, but in a different context. I think what's really difficult is that kind of way of working is very hard to measure and prove. I guess where the GPs at the deep end comes in is you're speaking to practitioners who are like, yeah, I get that. I don't always manage to do it. I certainly don't always manage to do it. That's what I'm aiming to do. But it's very hard for policymakers or people who've maybe not spent that time sitting in that room, hearing person after person after person coming in, to understand.
Thank you. I really appreciate that.
Alexandra?
Yes, thank you for that great talk. I have to say, I can absolutely relate to all that, what you said, and I love the description and the comparison of the deep end. My practice is with people living with HIV, so we definitely have a high proportion of people that are refugee and with unfavorable social determinants of health and this suffering from stigma. So I can absolutely relate. And the HIV medicine is actually the easy part. And I often find that we have to explain it to the residents that, well, there are the guidelines, and then here's real life. Yeah. And it's a whole different world, and you can. And it's a learning process, but I'm looking forward following your work in this. I think this is fascinating, and I think it can relate to many of our family physicians also at McGill. Many of the groupe de médecine familiale are in areas that are not necessarily favored. So thank you so much for this. It wasn't a question, but just really a very strong appreciation of your work and your presentation.
Oh, thank you. And I agree. I think there is something in it. The clinical stuff's not difficult. It's how you apply that in what can be very messy situations, and how you keep that relationship. And I think the thing that struck me is how difficult it is when the system isn't set up to support you. So I think particularly during COVID, I was getting really stressed, feeling like I just was failing all the time, and there was all this stuff and worrying about all the people who weren't even phoning us. And but I think I kind of realized, actually it's not that I'm not being patient-centered, or it's almost impossible to do that in 10 minutes when you've got do. And so I think some of it is trying to get people to understand the importance of these sort of things that you maybe only see if you're working in that area. So from the outside, it seems really, really simple. We just need to get people to, you know, to stop smoking, and we just need to get, you know, but actually when you're talking to someone and the only good thing that's happening in their life is their cigarette at the end of the day, you know, then that actually becomes a very difficult conversation. So yeah.
I agree, and I can confirm it's that we have the same issue with the healthcare system here, and the you know, the healthcare system thinking that everyone could just benefit from 10 minutes visit, and everyone could be the same, and everyone can connect to internet easily. So I think we're living the same challenges.
I think so. Yeah, yeah. The digital exclusion. I think we might see in 5 years when we actually get to see the impact of what it's had. It's worrying. I think we're not even just now beginning to really understand what happened over COVID and how much more was missed in our more vulnerable communities. Marian?
Thank you so much for your talk. Like Alexandra, I can completely relate to this type of practice. So my personal practice is in the Côte-des-Neiges area of Montreal and involves a lot of pregnant women. And I think what I find is exactly as you were talking about the relationship factor, like they'll identify me as safe and as somebody who's very helpful, but they don't understand, usually because of the systems from where they come, that there is no system, there is no structure behind me. So they tend not to trust that if I'm not there, that somebody else will take care of them just as well as I will, or perhaps even better. And so they kind of refuse ever to go to the walk-in clinic. They refuse to go see anybody else. They don't want to see the nurse, you know, to participate in multidisciplinary care. And it's challenging because they often do require more than one healthcare professional. And I'm just wondering if you have any tips about that.
Yeah, I think it can be difficult. And I'm guessing from what you're saying that you're maybe dealing with quite a high immigrant population. Is that right?
Yes.
Yeah. So I think that can be really difficult because you don't really always know exactly where people are coming from. I'm just reminded of the fact that when I was training, we had a very high Bangladeshi population. And every time I gave them a prescription, they'd say, "Is this a real pill, doctor?" And I was like, "Yes." I was like, well, what an odd question to ask. But then it turns out that where they came from in this rural part of Bangladesh, it was a kind of a bit hit or miss about whether the doctor would give you sugar or whether he'd give you a pill. And it just depended on the mood that you were in, and you just had to hope. But I was a year in that practice before I understood that. So I think some of it can be helpful when you understand that system. I think the other thing I do is, I rarely speak down anyone else in the health system, even if they maybe deserve it, because I don't think that's ever helpful. And try to explain to people the limits of what I can do and why I'm sending them to somebody. And if you know them well and you've built that relationship up, sort of saying, you know, it might be a bit difficult because they don't know that, but they'll get to know you. But also, and I don't know what it's like in Canada, but that primary, secondary, or would it be primary specialist, and that interface with other doctors doesn't always work super well. But I think particularly for people that struggle, if you say, look, they'll speak to me, I'll speak to them, you know, like if they know that there's that sort of that link, that they'll write to you, or if you've not heard of that can be helpful. And the other thing, I don't tend to offer this widely, but I do sometimes think it's sometimes with particularly people who've got literacy issues, I'll say, you know, if you're not really sure what happened, like come and see me a few weeks after and I'll go through the letter with you. Because I think actually that's something we maybe should do more often, because I think even people who know a lot leave their sort of secondary care thing and then are like, I've actually have no idea what happened there. And so I think sometimes saying, well, look, I can have a look, and then if after that discussion we still don't understand, I can send a letter and stuff. So those are some of the things. I think the thing is that's actually a really satisfying way to do medicine. That's how I like to do it. but I just can't do that for everyone because there's not time in the system. So you feel you have to pick your most vulnerable, because some of that stuff can take up to an hour. But when you do get hold of that, so what we could consult in what that specialist and have that discussion with them, then actually you can often come up with a really, really good plan. And that can work really well. The problem is that's an hour of your day that can be spent doing that. So you just can't do that for everyone. So it's that kind of frustrating, that frustrating thing where it can be such a satisfying way to practice, particularly with your complex patients. But it's just not always possible to do.
Thank you.
So Dr. Isabel Vidal had a comment and question in the chat.
All right.
She said, do you know what are the factors that would cause people to choose to practice in deprived areas? And also, do they play a role of advocate on local health authorities?
So to answer that first question, we're having an issue in the UK. We're having a general workforce crisis. I don't know if that's the same in Canada. So we don't have enough family physicians. And because of what I was saying, in that that there's this increased need, then in terms of in our most deprived communities, you do have, and the GPs at the Deep End group has been good at doing this with some of the younger doctors. You have doctors like me who've specifically chosen to go and work in these areas. They tend to be quite highly motivated. They tend to want to come along to our steering group, and they tend to be quite proactive in looking at how can we engage with our community. And then you have people who kind of end up there and end up quite jaded and overworked, and then quite often leave because the work's just really hard. And then there's people who a lot of general practice in the UK is kind of your locuming. I don't know if you have locums here, but sort of filling in a practice, and then a job comes up, and that's kind of, it's sort of a bit like that. Or to be honest, because we work in these small practice teams, I think honestly, if you look at it, one of the main reasons are people, if they pick a practice, pick one is it's because they want to work with people. So work with people who are like them. So either people who want to be really efficient, or people who want to make lots of money, or people who want to be really like me and touchy-feely and patient-centered. So they quite often will clump together. I don't really know what role of advocate in local health authorities means. I'm not, because this is maybe the UK, Scotland. Your local health authorities, they're the people who fund or make the decisions for.
It's advocating at the health board level.
Yeah. So we wouldn't have any official system for that. And that, I think what the Deep End group has probably done is given a vehicle for us to advocate as a group that maybe wasn't there before. Generally, most of our general practice, people will work in their practice. We do have a union, the British Medical Association. It's traditionally not been super interested in health inequalities. It's more interested in contracts. And we've got a Royal College of General Practitioners. They've got a health inequalities group kind of UK-wide. And they tend to do quite a bit of help with public health. And I think moving forward, that's something we need to look at. There's so much of an overlap between public health and family medicine, in terms of tackling this. Justin?
Yeah, hi there. Thank you so much
Hi.
for this talk. It reminds me very much of my work in the Bronx in New York. Very similar issues. I think one of the tensions that I am thinking about in relation to what you've been saying in this question period as well is that there's this tension. So in wealthy Western societies where there's in places where there's high rates of deprivation, I think that it attracts a certain type of clinician who finds deep satisfaction in the kinds of relationships that we can form with the people that we get to care for in these settings. I think if you look to successful primary care in low and middle income countries where they've actually done some really fantastic work in creating primary care capacity, the doctor is sort of the top of the funnel or the bottom of the funnel, and they create systems that are based on community health assessment and triage that work up towards the doctor. And I think there's this kind of fundamental tension here, because what we know about sort of really successful primary care systems for in low resource settings is in tension with this sort of the way that we provide care and the clinicians that we attract to those settings, and what they take from it. And it's just, it's something that I have thought a lot about when I was working in that setting and feeling like I just didn't have a team I both didn't have a team that was funded to provide the kind of care that I wanted to, and that took a lot of pressure off me. And I also derived a lot of satisfaction from, what is kind of ends up being in the minds of our patients and ourselves, kind of a savior role. I mean, our patient, to which, Marian attested. And so I just think it's a really interesting tension about how we think about planning primary care in these settings versus others in which there are more resources.
Yeah, so from what you're saying, in lower middle income countries, there's maybe a sort of wider team, and people would maybe say like a sort of lower level or a triage person. So the doctor wouldn't necessarily see everybody. Yeah, I agree. I think there's two things with that. I think certainly in the UK, I'm sure it's probably the same in Canada, there's a lot of stuff that we used to do in primary care that's now been done by other people. And some of that's been brilliant. So pharmacists in particular have been able to take a huge load of work off us. We used to do all these child development reviews that actually really are just done by our health visitors now, other than the 6-week check. And I'm not sure we've really missed them, to be honest. And there's a lot of work being done trying to put more ANPs and other people in the team to try and take that load. And the Scottish Government's plan is for us to become, they're wanting to call us consultant medical generalists, some kind of in the community. So we as doctors, the idea would be the doctors would really see the most complicated, most complex people. And I think there's a lot in that. I guess the thing is, at the moment, sometimes that odd, sore throat and or whatever, it just gives you 2 minutes that you can see someone and get them out the door and catch up. The thing is that there's also something about those little encounters that just slowly build up that relationship, because at some point that person is potentially going to end up complex. That makes me a little bit wary about that. And also my concern slightly is, who's complex, because somebody with diabetes but with multiple social issues, could require quite a bit. I think the thing is that certainly we tend to work in teams as a practice, so we tend to have nurses, pharmacists. I think quite often where those teams work really well together, there's almost that trust across the team. So those embedded workers that I was talking about, so for example, we put a financial worker into the practice team, and that financial worker had been in the health centre for 6 years, and that one financial worker in one small practice in the east of Glasgow got 6 times the amount of people as the 8 other financial workers spread across this other issue area in Glasgow, because of that team trust. So I think you're right. I think we maybe need to watch, and there is a conservative safer mentality, but I would say, like, our practice nurse has that same trust. There's people, our practice pharmacist is bringing that up. So the receptionists are absolutely key in the practice that I work in, because they're from the community. So that I think there is something about spreading the load. I think particularly at the moment, there's just not the capacity in the system for doctors to do everything. But my worry is particularly in the UK, where we're really struggling, and it's almost like we've just got to do whatever we need to. We just get rid of anything, that what we're risking losing as a profession is that continuity of care in order to make sure that we cope and survive. So I think they're kind of two extremes, and I would hope we can manage to get somewhere in the middle.
Great, thank you so much. Sorry to cut you off, but we have run out of time. But I just wanted to thank everyone for coming, and thank you so much again for your presentation. It was super insightful, and look forward to seeing you around the department in the next month or so. Thank you, everyone.
Thank you so much. Bye.
There's some nice comments in the chat too, you can read. Miriam.
Sorry, I was just reading the comments.
Well, I want to thank you again. I think this was really great. I have to say that I also have the bias. I think this is very great to see a clinician and a family physician doing such pertinent research also. So I think, thank you so much for that presentation. It was great.
Thank you very much. It's such a privilege to be able to present to you all, and yeah, thank you.
You're muted, Jeannie.
I'm jealous, Alexander, because in the UK, their academic primary care physicians, they get funding to get their advanced degree after training. Like after being a general practitioner, then they can apply for grants that'll help them to do a master's and then a PhD. That's what Marianne.
We have that here too, though. FRQS has that. Yeah, it's just not very popular with family physicians.
Oh, really? Yet. Okay. You have to be one of those people who likes working in deprived areas to do that.
Exactly. Do you have many family physicians who are clinician scientists in the UK? That's actually a good question.
It's an area that we recognise we need to grow in. And traditionally people have sort of ended up, if they have ended up in academic primary care, it's sort of been a bit of an accident. So there has been quite a bit of work by to the sort of our regional funding to I think the academic guys have managed to make the case that of the importance of academic primary care, but it is something you have to keep beating a drum because it's not as sexy or as immediately obvious as sort of oncology or all these other people, but actually it's really important. So certainly in Scotland, some of our most senior academics have actually worked really well with the government and stuff and have managed to slowly increase. So some of those jobs Jeannie was telling me about sort of only came out in the last 5-10 years, are kind of about trying to build capacity in the system. And then there are funding bodies we can apply to, but it's still really competitive. It's really hard to get funding to do a PhD as a GP. After that, there's a few more places you can apply for funding, but that's the sort of real bottleneck. And then, of course, a lot of clinicians, people tend to choose general practice because they enjoy the work. So actually, they quite often, certainly when you first start, it takes you a while to learn your trade. So what we're trying to do at the moment is, what about these people who've maybe been a GP for 5 to 6 years, and actually they're seeing something, they've got a really great research idea, it's absolutely based in clinical practice and it's a real need, but they don't have, how is there space to get them skills? And it doesn't always massively easily fit into the university structure of, they're probably not necessarily going to bring in huge grants and stuff. So I guess probably similar issues to you.
And like we do have those awards for MD doing a MSc, but they're often so small that it's better to actually continue working part-time than doing. And also once you started in practice, to actually be able to reduce is very complicated because you may lose your prem anyway. So it complicates the thing if you don't do it immediately after residency.
Well, I mean, that's the thing. So that is the thing. We get paid a lot less to do academic work. My mum is just like, I just don't understand. The more qualified you get, the less you're getting paid. It just makes no sense.
The same here.
And it's true. And I'm like, but it's hard because, to be honest, you're still getting paid. I'm getting paid much more than a lot of, than the non-doctors in my department. So I'm not complaining. And it's not been an issue for me, but I can see that across the workforce, if we're wanting to that people might refuse to or not want to go into research because it's a pay cut. But there's enough people, I think, that want to, even if it means, you know, you're not going to be in the breadline. So
well, thank you so much. I'm going to let you go. No, but thank you. That was
very
very
much. Thank you. And
Thank you for your
Cynthia.
support, Alexandra.
Thank you. Bye.
Bye.
Bye.